This should not be very long because all I'm covering is a basic overview, fluid and electrolytes. I believe in med-surg. She's only doing the concept, not getting into exemplar A with the imbalances, because you get A, B, and C with the kidneys and fluid electrolyte imbalances in Pharm 3. So I'm just covering some basics here of things you need to understand with fluid and electrolytes, because I'm sure it will be on your Kaplan for Pharm, and just a reintroduction because you need it all the way through med-surg, and it's just going to keep building as you go along, so you need a baseline. Okay, so some diuretics. You have loop diuretics, thiazides, and potassium sparing. Those are the three classes. Your loops are your furosemide, bumetanide, torsemide, ethacrynic acid, which I have never ever given. These are the two I want you to focus on, the furosemide and bumetanide, because you will see those throughout your nursing career, throughout nursing in college too. So your loop diuretics, those are your powerhouses. Those are the ones that are very, very strong. Those are the ones you're going to give when you really need that fluid off. Hypokalemia, hypomagnesemia, metabolic alkalosis. If you remember from your acid-base balance a little bit, metabolic because it's in your system, it's not respiratory. Alkalosis because you're losing your acid. When you're losing potassium, you're losing your acid, so it's a metabolic alkalosis risk. Big thing with loop diuretics is monitor that potassium. Remember, your magnesium is not part of any standard panel. Magnesium, no matter what panel, basic or comprehensive metabolic panel, magnesium is not on there. It's always an add-on. So a lot of times you will have to remind. But your big thing for furosemide and bumetanide is watching your potassium levels. That's where you may want to go back and look at foods that are high in potassium as far as patient teaching. Thiazide diuretics, because they inhibit the sodium chloride carrier, these are your two side effects: hyper or elevated calcium and low potassium. Elevated calcium, low potassium. The thiazide diuretic is not as potent in pulling that fluid off and lowering the potassium, but there are many people that are actually very sensitive and still get low potassium with it. And watch for high calcium. Calcium is not in your basic metabolic panel. To get your calcium level monitored, it has to be in your complete metabolic panel. Thyroid diuretics, hydrochlorothiazide is the most common one. Chlorthalidone, hydrochlorothiazide, metalazone, or Zeroxylin. So I want you to go stick with these last two here, hydrochlorothiazide and metalazone or Zeroxylin. Those, especially your hydrochlorothiazide, you will see that combined in all kinds of drugs and brought up throughout. Potassium sparing, the only one I need, well, I guess triamterene and spironolactone. Triamterene is used in a lot of blood pressure medicine. It's a combination of two different drugs, but it's potassium sparing. And your biggie is spironolactone. That one and aldactone will raise its head throughout pharmacology and med-surges. So triamterene and spironolactone is your potassium sparing. So what's that mean? They don't lose your potassium, so you're watching for hyperkalemia. Gynecomastia is another big side effect of spironolactone. So hyperkalemia. It's the only one that's not losing potassium, but you're watching for increased potassium. So when it's given with drugs, certain ACE inhibitors, ARBs, blood pressure pills, or with a potassium supplement, or somebody with a kidney issue that might be retaining it, you need to be watching for the hyperkalemia. And it's mentioned gynecomastia, which is pretty common with aldactone, spironolactone. IV fluids on here, isotonic. This D5W can be confusing, but it is there. You're mostly going to see normal saline LR. These are whole. See, they don't have any numbers. This is a combination. It's dextrose, 5% dextrose and water. This is lactated ringers. This is normal saline or 0.9% saline. So these are just, they don't cause no fluid shift. They're called isotonic. Same tonicity as intracellular fluid. Used for fluid and electrolyte placement. It's your LR is the one that has electrolytes in it. Watch for fluid overload, edema, and diluted lab values. Do not give it if they're in fluid overloaded, but okay. Isotonic, the most common ones you're going to see. Hypotonic, less solutes than intracellular fluid. So hypo, less than intracellular, so it's going to pull the fluid into the cells. The cells are going to swell. So these are ones that are smaller, half normal saline. I know it's 0.45 normal saline, that's called half normal saline. 2.5 D5W, because here you have 5% dextrose, this is 2.5% dextrose. You have 0.9%, this is a third of it, 0.33 normal saline. They're low numbers. Those are hypotonic, causes fluid to go into the cell, cells hydrate or swell. Watch for decreased blood pressure because the fluid is out of the intravascular space and into the cell space. Do not give in low blood pressure because it's going to cause the fluid to go into the cells. Out of the vascular space, pressure is going to drop more. Do not give in stroke, neuro, increased intracranial pressure, anything to do with the head, because it's going to cause the swelling in the brain. They're hypotonic. Do not give to a patient with a liver disease, trauma, or burns. You don't need them to burn. They're going to give lots and lots of isotonic fluids. You don't need the cells to swell. Hypertonic, more solute than intracellular, so the fluid is going to move from in the cell to the vascular space. So the cells are going to shrink because it's coming out of the cell. Hyper, coming out of the cells shrink. These are ones that are more so. So D5.5, so you have 5% dextrose, now you have D5.5% dextrose. You have your normal saline, now you have a combined 5% dextrose and normal saline. So mixing these two together, hyper. You have your lactated ringers here, you have 5% dextrose and lactated ringers. So you're adding the dextrose to everything, and here 5.5 normal saline with 5% dextrose. So it's a combination. Those are your hyper, these are your low numbers, partiality, these are the whole thing. Hypertonic are used for hypovolemia, vascular expansion, increased urine output post-op, for third spacing and DKA. So when you're studying your DKA, you most commonly are going to give them a D5, probably a D5L or a D5 normal saline, D5.5. When you're giving an insulin drip in DKA, you're actually mixing it in a dextrose because they have no volume. Their cells are shrunk, so you need to expand them. Significant hypovolemia, that's what happens in the beginning of that. Also your, what did I want to say? Vascular expansion. You may see it given after a major vascular surgery initially to get more fluid into the vascular space, and then they're going to go to isotonic. If the third spacing, the fluid is in the cells, not in the vascular space. That's why it's third spaced. It's not where the body can use it, so that's to pull the fluid back into the vascular space. Okay. Watch for hypervolemia because they can get overloaded very easily, increase in their sodium chloride, extravasation, cellular dehydration. Well, that's the dehydration because you're shrinking those cells. Hyperglycemia because look at the amount of dextrose you're dumping in there. Do not give in a renal or cardiac patient because of fluid overload. Do not give if they're dehydrated because the fluid's coming out of the cells. It should be pretty logical for you. And remember, fluid replacement oral if possible. You want to make sure you're watching their electrolytes. And fluid maintenance is 30 mils per kilogram of their body weight is how much you do for fluid replacement. I don't think I won't ask you that, sorry. I won't answer that last question. Blood transfusions. NCLEX and Kaplan will ask you about blood transfusions. This is some information on it. You're checking your blood bag, your RH type, your ABO group, expiration date, identification number, always hanging it with saline. So you flush to or prime your tubing with the saline, then close that clamp, spike your blood. Actually, you don't want a bunch of air in there. What I do is I put the saline up here. But anyway, then hang your blood. It is filtered. It goes to the patient. I was surprised when I was working, only RNs could pick up the blood from the blood bank, but I'm told now unlicensed sister personnel can go. Nurses have to check it at the bedside, but UAPs can pick it up. These are the different types of blood products. So you have your red blood cells. Like in the other, it's packed in there, so they take a lot of the volume out, so you get all the blood components without a tremendous amount of volume. Increases the amount of red blood cells after trauma or surgery. Fresh frozen is just your plasma. It's when you need coagulation factors and massive bleeding. Concentrated or platelets, that's it. It's just platelet transfusion to replace the low platelets. And cryoprecipitate fibrinogen. It's just the cryo in it. So your packed red blood cells are given over 2 to 4 hours, never faster. Your platelets and plasma are given very quickly, and so is your cryoprecipitate. Just remember, your fresh frozen is frozen, so you need to give the blood bank a warning of when you're going to hang it so you can go get it and hang it. Blood administration, NCLEX and Kaplan love this. Read this, put this in your memory. Checked by 2 nurses. It has to be at least 1 RN. Client's name, ID band, hospital, all these things. Do not warm the blood unless they're at risk for hypothermic response. They have certain machines that can do that. It's very rare. 2 to 4 hours, but no longer than 4 hours. Whatever's still hanging at 4 hours has to come down and be discarded. Always asking if they had previous transfusion reactions. Must get it hung and going within 30 minutes of receiving from the blood bank. Never add any medicine, anything, any other fluids other than your saline. That is a dedicated IV line. Baseline vital signs, and then per policy, it's usually within like 5 minutes and 15 minutes and 30 minutes, then every hour is usual, but always no severe reactions, most likely in the first 15 minutes, even the first 50 cc's of blood that goes in. So I always started nice and slow, so if they're going to react, and I stay there with them the first 15 minutes. And if blood tubing should be changed every 4 hours. The only time I've used tubing on more than one in a row is when I'm just putting it in a pressure bag and dumping it in on a GI bleeder. So really it's a new tubing with every bag. Transfusion reactions. Kaplan will ask you about these. This will probably be on your Kaplan, at the end of the semester for your Pharm. There's the mild facial flushing, hives, and rash. It can go to severe anxiety, wheezing, dyspnea. That's your allergic reaction to some component in there. Hemolytic is your deadly one. Hemolytic happens fast. I'm fortunate I've only seen it once, and it was within like 5 minutes. The temperature spiked. They were anxious. They were flushed. Their temp spiked, and their blood pressure dropped. With all reactions, stop the blood, and have a maintenance line of saline. I know you have your saline hooked up, but I always just grab a saline and a new tubing, disconnect that blood tubing, but do not discard it because blood bank may need it depending on what the reaction is. And then you have a febrile reaction, fever, chills, anxiety. This can happen at any point. This is the one that happens right away, and both of these can happen at any point. Stop the transfusion, start normal saline, save the blood container and tubing for blood bank. Draw a blood sample and collect urine sample. Observe for hematuria. Hemolytic occurs, this one, within minutes. It's the most critical. Febrile, non-hemolytic can happen within minutes or even hours after their transfusion. This I've seen near the end of it, but this is the one that can be much later, and this one immediately. Hyperkalemia. something, especially if you're discussing DKA or have discussed DKA, you should be familiar with your hyperkalemia. Non-potassium sparing diuretics, such as your furosemide given IV, will pull that potassium right down. Kxalate is given for hyperkalemia. It's like sorbitol. It's a thick syrupy solution. They either drink it or sometimes they're out and you're giving it down an NG tube. Sometimes you're actually doing a rectal tube and pulling it out that way by enema. It pulls the potassium out. That's Kxalate. Also, for more significant, giving glucose and insulin together, your regular insulin, over 15 to 30 minutes will pull that potassium out. Remember, your glucose and insulin follow each other. I mean, your potassium and glucose follow each other. Right? Yes. Sodium bicarb can be given, not as often as it used to be. Sometimes albuterol for hyperkalemia, but it's this glucose and Kxalate are the most common. Severe all of the above therapies should be utilized. Also calcium chloride. That's another I've seen used. Calcium chloride for hyperkalemia, because they are the opposite of each other. As calcium goes up, potassium goes down. As potassium goes up, calcium goes down. So if you give the calcium to raise the calcium, potassium goes down. Calcium chloride or calcium gluconate, it's between 1.5 and 3 grams IV over a few minutes. Watch for intravascular necrosis when giving potassium or chloride, calcium chloride or gluconate IV intravascular. So this goes more into the next section. I just felt these are pertinent, and you might see those on NCLEX, and I may ask about them. When you're replacing potassium, never administer IV push or IM. Never, ever, ever. 10 to 20 milliequivalents per hour maximum. That's something NCLEX likes, Kaplan likes. Never more than 20 milliequivalents of potassium per hour maximum. So if you've got 40 ordered, you're going to give it over 2 hours. Usually pharmacy will split it up. Some people can't even tolerate the 20 in their veins, and you might be given 10 milliequivalents per hour. Always use an IV pump. Always, 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 because you can kill them. Observe for infiltration, especially phlebitis, contraindicated in renal failure, obviously because they cannot excrete their potassium, and do not replace potassium on somebody getting a potassium-sparing diuretic. Hypermagnesemia and hypomagnesemia. Hyper, you're going to give calcium gluconate just like you do. So think of your mag and potassium together. So if mag goes up and potassium goes up, calcium goes down. If you give calcium gluconate, calcium chloride, your magnesium goes down and your potassium goes down. Hypomagnesemia, giving IV or oral replacement. Most labs say 1.8 for the lower level of your magnesium, I think to 2.2. I'm not real sure, but you want to look at your normal calcium, potassium, and magnesium levels. They are listed in your text. Oh, I wasn't recording. Okay, page 372, box 6.1. The ones I want you to know, these are on your blood levels. Your sodium, 135 to 145 milliequivalents per liter. Your potassium, of 3.5 to 5.3. Your chloride, 95 to 105. Your calcium total, 9 to 11 is the number I want you to give. Cross out calcium ionized. Go to magnesium. The first one, 1.5 to 2.5, cross out the other number. that is what I need you to remember at this stage of the game, okay? So commit those to memory, and I'm going to help you learn your labs as we go along. And that is the end of this recording.